Thank you for the opportunity to share this work. I would like to acknowledge my supportive doctoral committee members and co-authors, Sarah, Chris, and Danielle, and thank all study participants. I have no conflicts of interest to disclose. This study emerged from previous research in Ontario that explored the needs and experiences of mothers living with HIV during pregnancy and early postpartum. In the HIV mothering study, women shared their unique perinatal experiences, including HIV-specific treatments. Women also highlighted the exceptionalism of HIV, whereby they continue to face stigma, surveillance, and a sense of othering as mothers. I was interested to investigate if there was something happening within healthcare settings that produced the conditions for such experiences to occur. For example, do routine institutional arrangements that women interface produce the negative and challenging encounters that they have shared in previous research? Institutional ethnography is a suitable research strategy to investigate the connections between lived experiences in local settings, to the work and actions that people do within institutional contexts, and to the generalized social relations that coordinate, organize, and govern our everyday lives. IE operationalizes the critical feminist scholarship of Canadian sociologist Dorothy Smith, who asserts that inquiry must begin from the standpoint of real people doing and feeling things in local settings. These embodied experiences should be regarded as legitimate forms of knowledge to direct sociological inquiry. This ontological perspective is distinct from traditional sociology that begins from theoretical concepts and abstract ways of knowing. In IE, the researcher is focused on people who were actively involved in work and actions within institutional settings. Texts serve as a key connector to show how work is coordinated and why people do the things they do in healthcare settings. By making people's work visible, we can begin to make sense of how we are all connected and governed by ruling relations such as dominant ideologies and discourses. This IE inquiry was conducted within a regional hospital in Ontario. Interviews were conducted with 4 mothers and 12 healthcare providers working in HIV and maternity care settings. Interviews with women highlighted the work they do to receive care during pregnancy, at childbirth, and early postpartum, who they see, what they do, and what challenges they've encountered along the way. Provider interviews focused on the work that they do to deliver care to women and how their work is organized by texts like charts, guidelines, and institutional policies. The analytic process involved mapping text-work-text sequences of action to create a visual of how the healthcare institution was organized as it relates to perinatal care for women living with HIV. This map shows how text and work are connected as part of perinatal care, from the time that she reports her pregnancy to when she is discharged from hospital postpartum. The map shows how the work of HIV providers is connected to maternity care providers. Through this process of mapping, what became visible was the dominant role of risk discourses in coordinating healthcare providers' actions and organizing the doings of mothers living with HIV, all in the name of preventing perinatal HIV transmission and reducing risks to the fetus and infant. Maintaining adherence to HIV treatments was discussed by women and their providers. Women explained the work that they do to receive, fill, and take their prescriptions, and although sometimes difficult, they highlighted the importance of taking the medication to achieve an undetectable viral load to prevent transmission. As one woman reflected, "I was doing what my doctor was telling me always. You're a good mom because you did what we're always telling you. The medicine is going to save the baby. Why I'm doing that? I want to make my kids to be safe." The process of monitoring women's blood work and medication compliance was a focus for HIV providers. This monitoring corresponded with a frequent prenatal appointment schedule that women were expected to follow, all to reduce risks to the fetus, as this HIV specialist highlights. Women were expected to attend prenatal appointments based on the schedule set out by their providers. The increase in visits throughout pregnancy translated into additional burden on women's time and energy. Although maternity providers noted that the prenatal schedule was similar to what women without HIV would expect, women living with HIV perceived their schedule to be unique and a reflection of their HIV diagnosis, as this woman experienced. "A nurse called me a few times and said, 'You've got to come in, we haven't seen you. The clinic wants me to be here every 4 weeks. They never gave me an explanation, because you're HIV positive. I have little kids at home. I'm a single mom. It's an hour drive to get there. It's a long day to bring young children for 5 hours. Cab rides, food, diapers, all this stuff you have to bring. When asked what this participant thought about the nurse insisting that she comply, she responded, "My assumption and how I felt she was talking to me was, you're HIV positive, you're an ex-drug addict, you're not taking care. She was looking for something wrong because I'm HIV. This is my third pregnancy. I'm their lowest high-risk patient. I'm on my meds, I don't use drugs and alcohol, I'm perfectly healthy, I'm not doing anything that would put my baby at risk." This woman questioned how a rigid appointment schedule would further contribute to reducing HIV transmission, given that she was undetectable, taking her medications, and had significant experience. Providers equated the schedule with important moments to assess, monitor, and act upon complications and risk factors. This highlighted a disjuncture between women's and providers' perceptions of risk. Because the availability and scheduling of appointments was influenced by hospital organization and guidelines, which women had little control over, this created challenges for women who were balancing multiple responsibilities. Providers were asked about the rationale for women to keep a rigid appointment schedule, and it became evident that monitoring complications and assessing medical risk could be blurred with responding to social risk. As this obstetrician notes, compliance with visits could serve as a proxy for other possible risk factors. Is she taking her medications regularly? Does she have the resources at home to look after herself and the baby? In these circumstances, the woman's HIV status becomes a marker to consider not only medical risk, but also social risk. This assessment is occurring in a high-risk maternity care setting that is organized by risk as a dominant discourse. As the social worker remarks, if risks are identified, they enact one's duty to report, and this hooks women into systems of surveillance and child welfare that go beyond medical care they receive as pregnant women living with HIV. This IE inquiry revealed how risk was a complex social technology that intersected across a variety of interlocking sites for women, including the surveillance of her HIV status through medication and viral load testing, the monitoring of her pregnant body for possible medical complications, and the surveillance of social risks that could result in child welfare involvement. This monitoring occurred within a setting where risk-based perinatal care is the normative model, and the emphasis is on reducing risks to the fetus and infant. Within ruling regimes where the knowledges of those in positions of power are deemed authoritative, women's experiences of navigating such complex terrain, and the knowledge and expertise that they acquire as a result, can remain invisible and not valued as relevant and important. Instead, the institutional imperative to prevent perinatal HIV transmission and the healthcare providers who enact this imperative becomes the focus and source of authoritative knowledge. As a result, women's efforts and their specific needs and experiences as they navigate perinatal care become overshadowed by the institutional arrangements. The utility of IE is that it can be employed to identify targets for activism and systems-level change. Inquiries can reveal concrete points in a system that could be organized differently to improve care. This research reveals the importance of acknowledging women's efforts to engage in perinatal care. Women share their providers' goals to prevent perinatal HIV transmission. But women are juggling multiple pressures and responsibilities, and it should be acknowledged that how they participate in their care can be affected by their social positioning. It is important for healthcare providers and administrators to recognize how risk is an ideological discourse that organizes their work and the institutional arrangements that women encounter during the perinatal period. As such, we should critically reflect upon how risk is conceptualized and operationalized within clinical settings. Do the current institutional arrangements center the provision of care for the fetus and infant, challenge procedures that position mothers as a source of risk, and acknowledge the mother's strengths and experiences? Perhaps there are opportunities to innovate care models to facilitate cross-discipline collaboration. These ways of knowing can be integrated into routinized tasks and institutional protocols that direct the work of providers who care for mothers living with HIV. Thank you very much for the opportunity to share this work. Please contact me should you have any questions or comments.